Thank you so much, Julie, for incredibly important and subtle and nuanced refinements to issues of cognitive assessment that are so critical for us to make breakthroughs in developing therapies for Sanfilippo. So if we think about so many of the elements within today's presentations as focused on addressing unmet need or important need of our patients, one of the areas where this is especially true when it comes to disease that may not be fully addressed by things like ERT, et cetera, is in the corneal disease. So it's my pleasure to introduce Dr. Roberto Pineda, who will be speaking to us about issues of corneal disease and MPS. Thank you, Roberto.
Thank you very much. I want to thank the society and the organizing committee for inviting me. So I've spoken here a few times in the past 15 years, I guess, and it's great to be back. These are just some of my disclosures, which really are not relevant to today's talk, but I want to really focus on the role of corneal transplantation in MPS, and also the issues around transplantation and post surgical considerations, as well as post-operative issues. And I was really glad to see some fellow Minnesotans here today. I'm from Minneapolis. I attended the University of Minnesota, both for undergraduate and for medical school. And while I was there, I really got my first exposure to the MPS community. I was interested in ophthalmology, and my role model and hero at the time was Gail Summers in the Department of Ophthalmology there. Some of you might recognize some other people here. Minnesota was a big bone marrow transplantation center in the mid 80s and late 80s. And I was fortunate to be there then. So I had my first actually publication in ophthalmology regarding MPS and after bone marrow transplantation. And we had, it was kind of a start of something that's kind of cycled around later in my career, where I've become involved with the MPS community again. So I think this is actually my old presentation. Is this? Anyways, I'll go with it. So I'm going to review a little bit of the eye anatomy, because people get that some things mixed up, but the cornea is essentially the clear dome that covers the cornea, transparent cover, and we can see our iris there, and immediately behind the iris is the crystalline lens. And the retina is essentially the film that lines the back of the eye that transmits the information to the brain via the optic nerve. So I'm going to just cover briefly some ocular manifestations in mucopolysaccharidosis. And, many times the eye findings are some of the first symptoms before patients are actually diagnosed. And, with patients, MPS patients living longer and having potentially more ocular issues, it's very important to understand what the MPS community might be dealing with. So, the MPS has many ocular manifestations. Many patients are very farsighted or hyperopic. Corneal clouding is what I'm going to be mostly talking about, but they can also have changes in their retina. They can develop glaucoma, which is elevated eye pressure and damage to the optic nerve. And they can also have some other common disorders like a lazy eye, or which affects both eye movement and visual quality. And many of these are the results of accumulation of the glycosaminoglycans within the ocular structures. This is a classic table that you see, and certain conditions are much more affected than others with the eye findings. In particular, for corneal clouding, we typically MPS 1, 4, and 6 are the most commonly affected, and the ones I'm going to be focusing on. And what's really interesting about the different MPS disorders is that they can look very different. So you can, here's you know, 4 different patients with MPS 4, and the level of corneal involvement can be quite little. You can see the upper left-hand corner that the iris details are very clear. You can see everything, and in the bottom right-hand corner, you know, the iris details are very obscured. And so it's easy to diagnose when it's more advanced, but much can be very subtle in some cases. And in addition, as I already mentioned, there can be involvement of the retina in some of the conditions, as well as the optic nerve. The upper right-hand slide here shows some optic nerve swelling. And sometimes if the swelling is excessive, it can lead to loss of the axons and ganglion cells in the nerve, and essentially the nerve dies. So these are important to try to identify. These are just some pictures of the MPS patient with Shea, a little more milder version. And basically, you know, eye management, the MPS eye management has involved regarding both enzyme replacement therapy and bone marrow transplantation, has basically shown some slowing of progression in some of the ocular manifestations. But you know, there has not been much research in this particular area. One of the issues with bone marrow transplantation is it can be associated with a dry eye for patients. Patients can develop cataract, and you know, this is due to their use of systemic steroids and radiation patients may have seen. And this may also be a reason for significant reduction in their vision. Also, you can develop graft versus host disease that involves the eye, which can potentially lead to corneal perforation and need for other medications. So I mentioned before, we typically see the corneal clouding in MPS 1, 4, and 6. And just to talk a little bit about transplantation, you know, we do over 50,000 transplants in the United States every year. So it's the most frequently transplanted organ. And we are fortunate enough to have a very extensive banking system here in the US versus other countries. And historically, penetrating keratoplasty was the main procedure that was done and has been now done for over 120 years here. DALK, which is a deep anterior lamellar keratoplasty, is a modification of that, where we are basically preserving part of the patient's own cornea while doing the transplantation. And I'll go over some of that in just a minute. It is important to note that basically not every MPS patient is going to need a corneal transplant, but there are definitely a significant number of patients that would benefit from this procedure. And I think that it's important to understand, you know, what obviously to balance the benefit versus risks of this procedure, and understanding that the patient's vision could be limited by other conditions that affect the eye, such as retinal involvement or glaucoma, for example. And in addition, the MPS community is well aware of the anesthesia risks that patients undergo. We do need our patients to lie relatively flat to perform our surgeries. And there, of course, are intubation issues. And even at our own hospital, we have many requirements in order to perform surgery on MPS patients. Some patients do require general anesthesia. Some of the older patients who are cooperative can have just local anesthesia. And I've had patients who had issues with their general anesthesia at another location and came to see me, and we were able to do the surgery under local anesthesia and have very good results. The other thing that's important is to talk about how long these corneal transplants will last. And I think this is where the benefits of the partial replacement versus the full replacement come into play, and I'll touch on that. There's actually a really recent review in the Indian Journal of Ophthalmology that kind of went through the algorithm, you might say, of how to think about managing patients with mucopolysaccharidosis and different eye conditions. And I think it's a pretty good outline how to think about it, just diagnosing exactly what's going on for each patient, figuring out what their limitations are in terms of vision, and if it makes sense to proceed with surgery, and also just to consider the preoperative considerations for these patients. So I'm going to go back to our little anatomy lesson about the eye, but this specifically more about the cornea. So the cornea, it's pretty simple, has 5 layers. You have 5 fingers. And we have basically the epithelium, which is essentially like the skin of the cornea, and then a denser collagen structure called Bowman's layer. Then the stroma, which is essentially mostly collagen fibrils, and there's a few what we call keratocytes there. And this makes up the vast majority of the cornea. And then we have a very thin area called Descemet's membrane, and which is a basement membrane. And then the endothelium, which are the cells that are actually responsible for keeping the cornea clear by pumping water out. So in a full thickness transplant, I was kind of going back to this, we replace the whole cornea. So we're taking off all 5 layers. The eye is temporarily opened. We call this an open sky situation. And it does require sutures, which you can see in the photo below. And this is what most of the previous ophthalmic studies discussed when they referred to MPS patients undergoing corneal transplantation. In the deep anterior lamellar keratoplasty, or DALK, this is a more recent procedure, maybe focused on in the past 25 years. And here we're replacing those top 3 layers. That's about 90 to 95% of the whole cornea. So we're just leaving a very small percentage, which is the Descemet and endothelium. And this also requires sutures, but these sutures can be removed sooner. And that's one of the areas that people sometimes run into in terms of complications. And there's actually very few studies of the role of DALK surgery in MPS. The surgery looks something like this. I will show a short video, and you can either look away or close your eyes if you don't like looking at eye surgery. But we mark the cornea. We basically use this B shows a tree fine, which we use to cut down about 75% of the depth of the cornea. We then stick a cannula in the cornea and basically blow a big bubble into the center. We split it, and there's a natural dissection plane between the 3rd and 4th layer, and we essentially peel off that layer, and looks very, very clear once you remove that layer. And then we essentially take the donor cornea, which we take off the 4th and 5th layer, because the patient already has that, and we sew on a new one. So it's actually one of the more complicated surgeries we do for cornea. It takes longer than a traditional corneal transplant, but the outcomes are in many ways as good visually as a full thickness transplant, and potentially less immunologically risky for the patient. And I'll kind of go over some of that data. So in terms of like postoperative management, so it's one thing to do the surgery that is an hour and a half. It's another thing to deal with the postoperative course. And I think this is very important for the families to understand. Usually in the beginning, the vision's actually worse for the patient than it was beforehand. And that's because the cornea is swollen, there's a big scratch on the surface, there's a lot of tearing with that. But it does improve over the first few weeks quite a bit. And then, of course, over the following months. The expectation should be that the patient's still going to need some kind of visual correction, like glasses or contact lenses, and that there are multiple visits involved. You see the patient afterwards, a week later, then about a month later, and then every few months after that. And then that's eventually reduced to once or twice a year, but after several years. The other part of it is, of course, we need to put eye drops in. Patients need antibiotic drops, they need steroid drops. They're frequent in the beginning, 4 times a day for the first month. And these are tapered down slowly over the months. And then eventually we do leave most patients on 1 steroid drop a day to prevent transplant rejection. And there, of course, can be complications. These are actually usually due to broken sutures. Steroids can elevate eye pressure and cause glaucoma. Patients can get infections, and of course, there can be graft rejection. So even though these work very well, there are serious complications that the families need to take into consideration. So the other thing that we run into is, we're taking a corneal graft from a patient that may have a different shape or configuration and sewing it onto another person. So what happens sometimes is that the prescriptions can be quite different from the patient's original prescription. And that has its own set of problems. This is just this is a patient of ours who wears a contact lens. And that's very unusual. We don't have a lot of information about MPS patients and contact lens use, but they can be quite successful. This person has great vision with their contact lens. And also the prescription can be quite different. If you're nearsighted, the people here will know they have different numbers. This particular patient was a -3.5 in one eye with some moderate amount of astigmatism and -9.5 in the other. It's very hard to use glasses for that large a difference to get good binocular vision. And there are some lenses, special lenses patients can use for that, but this is a common issue, not just for MPS patients, but for all patients receiving transplantation. The results of corneal transplantation for MPS patients is relatively limited. There was a good study that was done in 2017. This came out of Europe. It looked at 48 MPS eyes in 32 patients. Most of them, 45 out of the 48, had a full thickness corneal transplant. And they had good follow-up, over 5 years of follow-up, and showed that most of the patients got in good visual improvement. Their corneal grafts remained clear. There was actually a moderate amount of rejection. This has not been my experience. Actually, my rejection rate has been 0. These are the things that are hard to tell from sometimes clinical studies. And comorbidities could be many things. I assume things like cataract and glaucoma. But you can obtain good, clear grafts for a large amount of time with these patients. But this is probably the best outcome for a large full thickness, large study for full thickness corneal transplantation in MPS patients. So I just wanted to kind of go through some cases here. I've kind of presented versions of this before, but the first one's a 17-year-old high school student who was referred to me for with MPS 1, who had significantly cloudy corneas. He had difficulty driving at night. His vision was stable for years, but in high school, there's a lot more schoolwork, and he was planning on trying to attend college the following year. He was very farsighted, which is very common, as I mentioned, and his best corrected vision had been about 20/40 by history. Just to throw these numbers out, we think of 20/20 as being normal. 20/40 is what most states use as driving without glasses. You need to have 20/40 or better vision. 20/70 is what's often used for maybe restricted daytime driving, not night driving, just for some reference. He had very thick corneas, which is also very typical of the MPS patients. I think part of the reason why they struggle with some things. They also, many of these patients, we don't talk about this so much, but they're often photophobic, very light sensitive, a lot of glare, and have issues around contrast. So in dim light, they have a much harder time seeing. And these are very hard things to measure quantitatively and also to address for patients. This is his appearance. Again, you can see quite a dense ground glass appearance of the corneas with loss of iris detail. He was actually receiving enzyme replacement therapy at that time. And we went ahead and actually tried to have him use the topical L-Durazyme to see if it would change anything about his corneal clarity, which it did not. And after a year of that, we went ahead and proceeded with a DALK procedure. I just will say that we actually, one of the questions that came up as I talked about those different 5 layers is how much of the MPS affects all of those layers, and particularly the endothelium, which is the cells that are responsible for helping to pump the water out of the cornea. And fortunately, several previous studies have shown that basically the Descemet's membrane, and which is layer 4 and layer 5, the endothelium, were actually looked pretty good on histopathology. We actually have looked over the years, have just had another recent study that looked at 15 corneas from MPS 1 patients between 2011 and 2020. And basically, we're able to show the kind of variations in amount of MPS that are located within the cornea. As I said before, the cornea is mostly made of extracellular matrix, which is essentially everything outside the cell. And the MPS is fairly diffusely involved in that. The bubbles here in the lower right-hand side are actually from that air bubble that I created during the DALK procedure. So again, treatment options for these types of patients could include the penetrating keratoplasty. We even can consider maybe a artificial cornea for a patient like this, which to my knowledge has never been performed, and then the DALK procedure. So this is, get ready to close your eyes and look away if you're not comfortable, but this is the procedure. Yes, okay. So, this is, we just mark the cornea. This is this tree fine to about 2/3 depth that we do. We have to, actually the corneas are so thick, we have to remove like part of the layer before we try to create this big bubble. We do this with a cannula. We make a partial dissection. This is the cannula with the air in it. You'll see it turn bright white very quickly. And that's splitting that 3rd and 4th layer. And then we have to kind of, we inject some what's called viscoelastic, which is gel, into the space. And then we cut off the surface of the cornea, which is the 3rd layer and above. And you can see how clear everything looks afterwards. This is the donor cornea. We're actually removing the 4th and 5th layer here. And then we basically place this on the cornea and we sew it into place for the patients. And again, this procedure takes about an hour and a half, and that's it. So this is, what this patient was doing 8 months after the surgery. His vision in the right eye had improved to 20/30, and actually correctable to 20/25 -2. His cornea was much thinner. You can see it was around 480 from around 750. And this is a picture 1 year later, and you can see the difference pre and post-operatively for the left eye here. And the patient right away expressed, how easy it was for him. He did drive, so he was very happy about that. And you can see here this, we call it a raccoon picture profile, but you can see the right eye, which was done first. You can, I should show up there pretty well. If you look at the outside, you can see there's kind of a light gray area. It's darker gray on the left than the right. And that we think is because the keratocytes in the donor cornea have migrated or have into the host cornea and allowed to break down some of the excess enzyme. So we published our results here on some indications for the outcomes of DALK surgery in these patients. And basically we're able to show that all of the patients did have notable improvement in their vision. In terms of case 2, this is was a 15-year-old who had bone marrow transplantation with total body irradiation and also had best corrected vision to about 2100. Again, same thing, very thick corneas. And here's the picture here of the corneas. You can see again, loss of iris detail. And that basically he underwent DALK surgery, but sometimes the two tissues don't adhere, and we have to rebubble and do other maneuvers, but it did attach after 3 weeks. He did need a contact lens also for a big scratch that didn't heal up fast, but he ended up doing very well with that. And by 6 months, his vision was 20/70, and mostly limited because he had a cataract from his prior irradiation. And he eventually underwent cataract surgery for that as well and had the other eye done. And this is his appearance 7 weeks after the corneal transplantation. And just some other pictures of before and after the DULC procedure in patients with MPS. So the main, we want to compare the benefits of full thickness corneal transplant to partial replacement. In penetrating keratoplasty, there's a higher risk of rejection. You tend to have higher astigmatism, as well as a higher chance of glaucoma, as well as iris issues. The main issue with the DULC procedure is that it has a higher risk of interface haze, because you have this separation between the third and fourth layer with the donor cornea. But otherwise, it is considered much safer. Basically, studies looking at DULC in general versus corneal transplantation in general, not in MPS specifically, show that the DULC does better in the long term, with basically estimations that compared to a full thickness transplant, which might last 17 years, a DULC procedure might last nearly 50 years. And that's been shown in a few studies. We came out with a study just looking at the 12 eyes of 7 of our patients with more longer term follow-up. And again, in those cases, they all had improvement in vision. They all had improvement in their corneal thickness, and we had no episodes of transplant rejection. So fortunately, I continue to see a lot of the MPS patients. I'm happy to announce we are planning to do an investigation of impact of visual function in patients with MPS and their caregivers. And then I'll be working with one of our Harvard medical students here, Nathan Grant, who will be working with me on this study, which I think will help really raise awareness about the issues around vision for both the MPS patients and their caregivers. And hopefully this information will help both clinicians, providers, and policymakers, industry, and community all develop kind of future resources for support around vision care in the MPS community. So in summary, I think ocular findings are very common in MPS, particularly corneal clouding. The systemic therapies, in which we've heard a lot about today, have increased life expectancy and have renewed the focus on quality of life measures such as vision. Again, because there can be many issues with vision around MPS, we do recommend regular eye exams and, if needed, potential corneal transplantation. Both full thickness transplants and partial thickness transplants are viable options, but we do favor the DULC procedure over PK for its lower risks. And of course, we now have up to 14 years of experience with DULC in MPS and have had very good results. So thank you very much, and happy to answer any questions.